All right, thank you. Welcome, everybody. I hope we have an informative session for you today. I'm Dr. Edward Gold. I'm the chairman of medicine at Pascack Valley Medical Center. To my left here is Dr. Jason Sayanlar, who's the new chief of cardiology at Pascack Valley. And to my right is Dr. Ayushi Dixit, who is one of our endocrinologists and also has a specialty in metabolism and weight management. So today we're going to talk about cholesterol in you. And somebody said to me, the good, the bad, and the indifferent. And I think that's not a bad topic. So I'm going to start off basically with Dr. Dixit and ask her a question. What's the biggest fallacy you hear about people with their cholesterols?
I guess when people are searching for good fats to put on their food and just adding unnecessary things that they think, like, for example, avocados or drizzling olive oil or, looking for some kind of good fat when it should really just be part of your balanced diet. You shouldn't have to add anything extra.
So basically what you're saying is you need to have a complete diet rather than just a selective diet. Okay, that's a reasonable thing. Jason, why is cholesterol important? You're a cardiologist, so
right.
There's a reason it's important to you. You're a diabetologist. It's a reason it's important to you. So let's ask you first.
Well, thank you, first of all, for having us here. I think it's important because a focus of my career and professional interests is prevention, right? Prevention of cardiovascular disease, which may not sound as sexy as the things that we hear about in terms of when someone's coming in with a heart attack or getting rushed to the hospital, those TV shows that you see. But obviously, prevention is very, very important. So cholesterol, I think, is like the foundation of that. We talk about family history and we talk about, what can you do to reduce your cardiovascular risk? And I think cholesterol is probably the biggest, modifiable risk factor next to blood pressure, of course. So does that answer your question?
Yeah, I think so. Why is it important for somebody who's treating diabetes?
So the most common cause of death in patients who have diabetes also they have an increased risk of heart disease. So if it was just a regular person, it's important to have a normal cholesterol level. But if you are diabetic, we have a different set of rules and different levels that we want to keep the cholesterol under just because you already have a higher chance of dying from heart disease.
Okay, so let's talk a little bit about cholesterol itself. You hear terms the good cholesterol, the bad cholesterol, the indifferent cholesterol. Is it important? What level should it be? From the point of view of a cardiologist, what's a good and a bad cholesterol mean to somebody?
Right, and I think the reason that's a good question is because there's no perfect answer for everybody. I think it needs to be personalized for the patient, right? And that's why, we're in this era now of personalized medicine where, it's not just cookie cutter across the board for every single person that they should be on a cholesterol pill or not on a cholesterol pill, right? We have to weigh their risk factors. And there's ways to do that, obviously with like scoring systems, but also family history is a huge component of that, right? So, if you're talking about someone whose father died of a heart attack before he turned 50, your antennae are going to be up a little bit more about cholesterol. And you may want to be checking, you may want to be a little bit more aggressive. Certainly there are some hard and fast numbers that, when a patient comes to the clinic and you see a cholesterol value and it's sky high, I think, everyone's eyebrows get a little bit raised like, whoa, that's high. But for the most part, I think it has to be personalized to the patient, how aggressive to be. If you have a personal history of cardiovascular disease, having stents, having bypass, those are the people that we're the most aggressive in, right? We want the cholesterol as low as possible. If it's just primary prevention, meaning you've never had any stents, heart attacks, strokes, things like that, then, there are other guidelines, but not as aggressive if you've had a personal cardiac history.
What about diabetics? It's a little different for them, isn't it?
Well, for diabetics, like I said before, since your chances of having cardiovascular disease, I guess, are a little bit more serious than a normal person, but it's also relates a lot to your weight. The treatment of diabetes is all about, if it's type 2, usually getting the weight down. But a lot of people end up with diabetes because of their dietary choices, and hand in hand with that comes high cholesterol levels. So it's kind of important to try and tackle both if they have cholesterol issues and diabetes with the diet, just to improve outcomes.
Yeah. I think people always, I'm going to just say something. People always talk about the good cholesterol and the bad cholesterol and the total cholesterol. And there are other little factors that we sometimes measure that are technical, like something called LP little a or something like that. But basically, the general guidelines are we'd like to have everybody's cholesterol total about 200 or less. We'd like to have the bad cholesterol, the LDL, which is the real modifiable factor, at 100 or less. And the HDL ideally should be 40 or higher. Okay? The higher the HDL, this is a protective factor. The lower the HDL, you lose that protective factor. The higher the LDL, that through the pathophysiology, which we're not going to try to explain here today, that really is what gets into the arteries, into the walls, and causes the inflammation and causes the damage. So if your LDL cholesterol is 160, that's probably not a good thing. There are some unusual situations. So I may see a patient who comes in to see me and their total cholesterol is 260, but their HDL cholesterol is 90, really, really high. And their LDL cholesterol is 120, 130, something like that. And when if you work with your primary care physician using the predictive models that we have, we can pretty much guess what your risk factors are for heart disease are. And if your risk is high enough, you go on a medication. But if it's not, then you don't. And that's really what it comes down to. How much is cholesterol fluctuations due to heredity, and how much is due to dietary?
There are some genetic conditions which can put you at a risk of having higher cholesterol levels. Sometimes there's patients who come in with really high LDL levels, and no matter what, we just can't get them down. That's usually something that's hereditary. That could be the same for total cholesterol and sometimes triglycerides. Sometimes you can have genetic problems where you have low levels of everything. But the diet does play a big part. That's usually the first line. We try and change the diet and get it down as much as we can. I have seen people come off of medications just by changing their diet and losing weight, which helps because not all the medications make everyone feel that great. So the diet plays a big part.
Well, people always ask me about, are there any specific supplements or vitamins or pills or, you mentioned avocados. Some people call it about almonds, that make red yeast. Does this stuff really work, or does it not work, or is it worthwhile? I mean, I have people come in and they're on 3 medicines and 75 nutrients. And I always, I try to tell them, you're probably not doing anything, but what do you think?
So I think if you're trying to switch things out, for example, eating more salmon than red meat, then you're making a change. But if you're just adding these to your diet already, it's probably not going to help. I think you definitely have to switch the bad things out. It's not going to cancel them out. Switching to oils like sunflower oil or olive oil or soybean oil, which is not very common, is better for you. But as long as there aren't other things in your diet, like if you go to get fast food regularly, that kind of stuff is not really going to cancel it out. It's not going to help if you're doing all of this at the same time. You really have to clean out the rest of your diet. I have heard about the red yeast thing. Some people take that because they don't like statins. They don't like the side effects. Sometimes it does help. I don't think it really causes that much harm. So it's not a bad idea to try it if you're intolerant to statins.
But the effectiveness is not going to be to the same level.
Yeah, I don't know if I would trust it all on its own.
Yeah.
I think I'd put it somewhere in the mild statin type effect. I think it does have some natural cholesterol lowering capabilities, but like Dr. Gold said, it's definitely the efficacy is not going to be as much as something that's prescribed. But I do think there is, some, I don't want to say evidence, but some, history of like red yeast rice having the ability to lower your cholesterol levels, but certainly not too potently.
So let's talk a minute about the cholesterol medicines, because think everybody's on a statin. I'm on a statin. I mean, everybody seems to be. And if you're not, you probably will be. But what's the basis of treating cholesterol from a cardiologist's point of view?
Yeah, so I think it's evolved. I think it's evolved a lot over time, and in really the last 30 or 40 years, it's come a huge way. There's several different classes of medications. When you say cholesterol, people's face turns a different color, in the clinic, because they're so scared they're going to get the dreaded S word, the statin. And a lot of times they may not need it, like we talked about. That's a whole different question of if someone needs to be on a cholesterol medication. But if they do, the question of how, and that's where statins come in. So, I tell people that there's two ways really that cholesterol ends up floating through your bloodstream. One way is obviously through what you're taking in through the diet, and the other is through how much you're making inside your body, inside the liver to be specific. So cholesterol medications such as statins do work specifically on the liver to decrease how much your body is making. So if you do have a strong family history of cholesterol problems, a father who had a heart attack before he turned 50 or, just really high numbers, the chances are pretty good that, there's something genetically there that might be an overproduction of cholesterol in the body, and that's where statins really come into play. They are very good for decreasing how much your body is making cholesterol. And the higher the dose usually means that the less your body will make, although there is a ceiling effect, I believe, on a lot of them. And, different cholesterol medications, different statins are tolerated differently. I wouldn't, everyone's body is different. Different people tolerate the side effects differently. I think the assumption that when you go on a statin, you're going to have side effects is wrong. Pretty good data out there that, if I actually read this trial about patients who were blinded. Some people got a sugar pill and some people got statins. And then they asked them if they had the dreaded side effects, which include muscle aches, right? And up to 90% of people did not have anything, right? So that is to say that maybe 10% or less did. So they're not benign medications, but, I wouldn't assume just because you go on it, you're going to get the side effects. And I think the dose is also important.
Yeah, I agree. That's my personal experience also. I think that because statins have been around for 30 plus years now, and the original statins, the first ones that came out, had more side effects than the ones we're using now. And people have to understand that. Also, when we first came out, we were having people come in every 3 months for liver function tests, and that's not really necessary. I usually basically have my patients come in who have high cholesterol twice a year to take the cholesterol. It's sort of a gut check on them, because even if you're taking the pill, if you don't follow the diet,
right.
you're overcoming the pill.
You may be making less but taking in more,
right,
and then canceling it out. Yeah.
Taking a cholesterol medicine is not a license to go have fried chicken. Okay, it just doesn't work that way.
Yeah.
Well, speaking of fried chicken, what's the relationship of the amount of cholesterol you take in and the amount of fats you take in? People always say, well, I don't have any cholesterol in my diet.
Well, you do need a little bit of fat. Obviously, you need to have like a normal, well-rounded diet, but I think it just depends on how the food is prepared. There's good fats and then there's bad fats. Obviously, if you grill salmon versus deep frying chicken, it's going to have a different amount of cholesterol and just grams of fat. But I think, it just depends on how the food that you're eating is prepared.
What's more important, the amount of fats in your diet or the amount of cholesterol in your
diet? I would kind of look at it as you shouldn't try and like reach a goal to have like this many grams of fat and cholesterol, especially for my patients who are most of them are diabetics. I would try to keep it as low as possible, really. But not like you can't cut it out, obviously, but I would just, I don't know how to explain it. I just don't want to emphasize that like you have to have this much, because then if you give people that, then they go and they kind of do crazy things. Like if you say like, try a keto diet, they market all kinds of things that are keto, but it's like pork rinds and nacho cheese. And then they think they're on a keto diet, and then they come back and, things are just out of control. So
those pork rinds will do it to you every time. I'll tell you.
Not too many doctors prescribing.
So,
Brian.
so,
Yeah.
so, so this is actually for both of you. So what is a heart healthy diet? People talk about that all the time.
I think what has the best, data on it in the long term is a Mediterranean diet. I think, olive oil should be the cornerstone of that, not to excess, to Dr. Dixit's point. I think it needs to be in moderation. Everything has to be in moderation. It's unfortunate, but it's true, right? But you're talking about lean meats, and you should be really avoiding red meat. But, lean proteins like chicken and fish that are high in fish oil that we talked about. But that's the cornerstone. And, of course, your greens. So fill up on those types of things as opposed to the high-fat type of diets.
He definitely said it better than I did.
Well, what do you think about these diets? The keto diet and all those things.
I've seen people do really well on it, but I've also seen things marketed in stores that just say keto on the front, and everyone thinks like, oh, I had like something earlier today that was keto, but you can't just have one keto thing and think that you're doing keto. That's changing your body's whole chemistry. Everything you have to do has to be keto. You have to follow some rules. So if you're doing keto, I don't think you should, kind of go on that journey alone. I think you should definitely talk to your doctor, make sure that you have like a good idea of what you're eating and following the rules. Also, if you have a history of heart disease in your family, it's probably not the best idea. If you are already on cholesterol medication, probably not the best idea. Some alternatives that I think might be better would be like South Beach diet or Atkins diet or the Mediterranean diet, where you're not focusing so much on food that's so heavy in fat.
Yeah, and one proviso on that: a Mediterranean diet is not a pound of pasta every day. Okay, it's a balanced diet that includes proteins and legumes and vegetables, and usually tastes pretty good. But it's not going out and having a pound of pasta primavera every night.
In general, when you're eating a pound of something, it's probably not consistent with a good diet, even keto or Mediterranean diets.
Right, exactly. So it's a specific question people are asking. What do I do if I'm taking on a cholesterol medicine, I miss a dose? What should I do? Do I take 2 the next day? Do I take 3? What do I do?
So, I think with cholesterol, the good and bad news about it is that it's a long-term risk, right? It's not a short-term risk like this day. God forbid you're going to have a heart attack if you missed your dose of your cholesterol medication. So I probably would just take the next dose that you have. I would not double up personally. It's about the long term. It takes several weeks even to see an effect in your bloodstream because, again, it goes back to how does it work? It cuts down on the production of cholesterol that's being made in your liver. So that factory has to shut down or at least to, halt production, right? And that's not going to happen in one day. You have to stop it, and it takes a couple of weeks before we even check the cholesterol levels to see if they've budged.
Okay, fine. Did anybody bring any questions in for us? All right, good.
Can people of all age groups have high cholesterol?
If I'd say if you're an adult, it would make more sense that we go based on, the ranges put forth by whatever lab you're using. But if you're younger and have these issues, it's probably genetic. Most of the time, I don't see these kinds of levels in people who are younger. I see it once they start to have, chronic diseases like diabetes and obesity.
Yeah. There was a study done during I believe it was the Korean War, or the Vietnam War, on soldiers, young men, autopsy after passing in battle, and a good percentage of those people, those young men, already had atherosclerosis, which is the beginning of hardening of the arteries. Right. So there are people who walk around who have high cholesterol at a young age, and they may need to be treated if you find out that they have. You've got somebody who's got a genetic predisposition. Their mother and their father had a heart attack, and they've got a cholesterol of 280 and an LDL of 150. If they're 25 years of age, I treat them. Would you treat them?
Yeah.
Would you?
I would, but I would say the caveat that, it gets tricky if they're young women because the statins interfere if you're, with pregnancy. So that gets really dicey. And then you have to really weigh the pros and cons of that specific cholesterol medication versus some other supplement type stuff. Because I think the key is that it's the cholesterol levels over time, right? So time is not your friend when it comes to cholesterol, unfortunately. And, when you're younger, the likelihood is less. But as Dr. Gold said, I've seen patients in their 30s, their 40s, unfortunately have, evidence of heart disease. And that's a really good, point to bring up here is, how do we see that, right? A lot of people ask me that, like, how do you know if you have evidence of heart disease when you're young like that, right? So there's actually really good tests for that now. In the old days, all we referred to were blood tests. That's all we had. And I give this really bad example. If you guys will bear with me, please don't laugh at me. But I tell people that cholesterol is a lot like snow, right? So you can look out your window and see if it's snowing, right? That's like the cholesterol right now, how fast it's coming down, right? That's like checking a blood test. What are the cholesterol levels like today? But if you want to see how much has come down over time and if it's starting to impact the roads, right? If you call your arteries the roads. Again, these are the bad examples I use with my patients. And if my patients are on the line, they know this story. But we have tests now to look at arteries and see, is the cholesterol sticking to the arteries? Is it starting to deposit in the arteries? Is there inflammation in the arteries? And eventually, if it's been there long enough, is it hardening? And we call that calcification, right? Anything in the body that's there for a while will calcify. And so there's a couple really good tests. One of them is called the calcium score. You may have heard about that. We do offer screenings for that here, very reasonably priced at Pascack Valley to see what your personal score is, especially if you have a family history of heart disease.
$99 here. So
$99, can't get a better deal than that. And, there's other imaging tests to look at arteries, even a carotid ultrasound, which is the artery in your neck, which is a big artery and can be seen with an ultrasound. If you can see that and detect plaque, which is, the deposition of the cholesterol, among other things, in the arteries, that's another sign that you may be, retaining the cholesterol and you have a cholesterol problem. Meaning, we talked about the HDL being the good, that's clearing the arteries of the cholesterol, for lack of a better example, and the LDL being the bad, that's depositing more cholesterol. So everyone's body is different. Everybody deposits cholesterol differently. Some people may have high levels and not deposit cholesterol, and some people may have not crazy levels, but they are retaining the cholesterol and developing atherosclerosis, which is the process we're talking about. So it really just depends on the person and other risk factors such as diabetes, unfortunately, which is a disease of inflammation. So we're not, in the ice age anymore where we're just looking at numbers. We can do pictures. Pictures are worth 1,000 words, right?
Yeah. And the situation does change with diabetics. Mm-hmm. Much lower threshold to take an action in a diabetic.
Okay, so our next one is, what are the best veggies to eat? My cholesterol is great. I'm a vegetarian. I drink almond milk. Just curious about what you think.
Was it veggies, you said?
Yeah.
Well, I think any kind of greens are good. I think it's better to choose something that's less starchy, and obviously the way you prepare them. So baked is best. I would go with spinach, Brussels sprouts, green beans, any kind of salad, and as long as it's not deep fried, I think it should be okay. Obviously, I mentioned avocados earlier. It's fine as long as you don't overdo it. I just don't think you need to keep adding things thinking that adding a good fat is really doing much for you. If you want it for taste and moderation, I think it's fine. But anything green, and if you are having a starch, that's fine. We're all going to eat fries and potatoes and things like that from time to time, just as long as it's not every day.
Is it true that in order to lower your cholesterol levels, it's best to stop taking processed carbohydrates?
It does help, especially with levels like triglycerides. That's another type of cholesterol we didn't touch much on, but it definitely helps bring that down. And it can help with the total cholesterol and the LDL, but more so with the total cholesterol and the triglycerides.
Well, just speaking of triglycerides, let's get Jason. How important are triglycerides is compared to cholesterol for heart disease?
Yeah, I think it's an evolving story. In the old days, I think triglycerides were kind of forgotten and ignored. And, I had a mentor tell me when I trained in fellowship, he said, I don't really think about triglycerides until they hit 1,000. And, there's other risks besides heart disease when it comes to triglycerides or fats, which are even inflammation of your pancreas or pancreatitis. So I think the newer data, there's newer medications that can help with triglycerides. But the newer data is telling us that there is an independent risk factor with high triglycerides in terms of cardiovascular disease, and not just disease, meaning the narrowings of the arteries, but also events, right? So an event would be a cardiovascular event would be something such as a heart attack or a stroke. So now I think the story that's evolving is that we do have to pay attention to it. Fish oil, which is something you can get over the counter, is something that can lower your triglyceride levels. There's different preparations of it. It's a supplement, so it's not something that you can just say, go out and get this amount of fish oil. There's different preparations from different companies, but there's newer agents now that we are prescribing, especially for the highest risk groups, for people who have a history of cardiovascular disease and high triglycerides. So we are trying to target that more now. But I think LDL still, if you had to pick one bad thing for all comers, which is generally not a good rule, I think LDL or the bad cholesterol is still the greatest villain in the story here.
Okay.
At what cholesterol level would you recommend someone to pay for a calcium score test?
I don't think it's the level. Like I said, I think it has to do with the history. I think it has to do with your history and, more importantly, your family history. We have risk factors, such as high blood pressure, cholesterol, diabetes, age. Unfortunately, age is a risk factor, right? But, like we talked about, if you have a very strong family history of heart disease, I think that's what calcium score is best for. I have people who are extremely athletic. They've run multiple marathons, but they've had someone have a heart attack, at a young age in their family. And their cholesterol levels may be okay, maybe a little high. I think that the ratio, and this may be controversial for you guys, but I think the ratio is not of good to bad cholesterol isn't as powerful as it used to be. We used to use that a lot. Oh, you have a good ratio. You have a good HDL and an okay LDL, so you have a protective factor. I think we really don't know how these things are shaking out in people's arteries until you look at a lot of scans of calcium scores. You get some surprising values. I mean, if you see enough of these calcium score results come back, you see someone who's in great shape, but their father had a heart attack, or their mother. Let's not just vilify the fathers. And you say, wow, you have plaque. And it's surprising that you have plaque depositing in your artery. I think we should be a little bit more aggressive with your cholesterol medication. So it's not the age, or I think it should be more about the story. And that's why it's a good idea to, maybe get a consultation.
How does heredity play a role exactly? I have high cholesterol, so does my mother, grandmother, and sister.
Well, in these kinds of cases, sometimes diet won't really help. Some people, it just kind of runs in the family, and we can try putting them on a diet. Obviously, the diet is important. It's not that they can just eat whatever they want, because it's not going to change much, but we would be more, I think, inclined to treat them medically and try and get the cholesterol levels under control. It doesn't always work, even with the medications that we're using on other people with heart disease and diabetes, but I think it's just as risky, even if you don't have heart disease and diabetes.
When you have a family history like that, and high cholesterol and not the family, basically there's a biochemical difference between you and somebody else that is, you're either making too much cholesterol or you're not clearing the cholesterol from your body, and so you're stuck with it. Okay, I had a mentor who very often said, "Listen, you can't fight your genes. You really can't change your genes, and they are what they are, and so you have to face it."
Not yet, maybe one day. That's
Maybe
where we're
someday.
going.
Yeah, they're
that's where we're
working on
going.
it. Yeah, I know. I watched Star Trek too. So it's right now we can't do that, and so one of the biggest things that I see doing primary care with people is just getting them to realize they have a problem. Understanding that they have a problem. And the other thing is that, anybody can go on a diet, right? You can lose 15, 20 pounds. You look great. But if you don't stay on the diet
Right.
forever, it's not going to do you any good. And that's something that it's very hard and sometimes very frustrating to get somebody to realize.
Well, that's where I think these tiebreaker tests come in handy,
Yeah.
because if you see somebody with a risk factor and you say, let's get one of these tiebreaker tests, like a calcium calcium score or a carotid test, and you say, look, you clearly having effects on your body and your arteries, that's usually the push.
Right.
I
And if you
found,
got somebody who comes back with a 0 on a calcium score,
it gives you a little confidence. Yeah.
gives you a little confidence.
Yeah, I mean, it's not forever. There is a half-life on how long those results will stay valid for, right? You can't get a calcium score at age 30 and then wait 30 years, but still, it's valuable.
What is hyperlipidemia?
Okay. It basically means, in like regular terms, high cholesterol levels. So we have some ranges, usually over 200, like we mentioned earlier, for total cholesterol, usually over 150 for the triglycerides, and for the LDL in a regular person over 100. But in diabetics, we are a little bit more strict. We want the levels under 70. So if it's over 70, we would say that you have hyperlipidemia.
Are there other risk factors that I need to watch for or control because of my cholesterol levels?
Yeah, so unfortunately, some of these things go hand in hand together, right? And things that you can look out for that come with hyperlipidemia are things such as hypertension, which is high blood pressure, and also diabetes. And all of these things kind of make up a metabolic syndrome, and I would be stepping on Dr. Dixit's toes here if I started talking about metabolic syndrome. But, these are things that are also linked to obesity, and they're all bad. They're not good things. They raise your risk levels for cardiovascular events. So that's why I pay attention to them. But the things that you do to treat them, they all go hand in hand as well, right? So losing weight helps, exercise helps, and then of course the diet is important, with or without the weight loss. But what you're taking in is going to make a difference in some people more than others. But we have to pay attention to it.
I always often have people come and say, "Well, I don't have diabetes," okay, but they're what we measure is something called an A1C, which is a long-term measure of blood sugar. It's 5.8, 5.9, which is above 6. So, do they have diabetes? Do they need to be treated like a diabetic in terms of their cholesterol? My bias is that I tend to try to treat them like a diabetic and be aggressive about it, and try to explain to them that no, you're not. It's like being pregnant. You're not a little bit pregnant. Okay,
Yeah.
am I right?
Can you be a little bit
Can
diabetic?
you be a
So,
little bit diabetic?
I see what you're saying. I have a lot of people as well that they've just been in the pre-diabetes range for a while, and that's fine. Also, it depends on how old they are. We are a little less strict in what we want the glucose control to be, but I would still take their cholesterol just as seriously as I would for a diabetic. I would probably try to treat it as much as I can with diet if the numbers aren't astronomically high, but if they are, then I would think, medical therapy is fine.
So from each one of your perspectives and specialties, how do I prevent high cholesterol?
It's a tough question.
It's a very tough question. Well, we've already said you can't change your genes, so you're stuck with what you inherited. In all honesty, there's two things I think about, and it's diet and it's exercise. And the dietary expert is right here. Okay, so I'll let you talk about the diet.
So what I would say is to make sure that you're, exercising appropriately in your diet, is everything that you're doing is like working towards getting your cholesterol down. Start with what is your weight, with your height, what is your BMI, what range do you fall into? Are you normal, overweight, obese? Where do you want to get to? Obviously, we want everyone's body mass index to be under 25, but here our guidelines are a little different. Under 27 is acceptable, but I would start with trying to put yourself on a diet and some kind of workout plan that can get your weight lower. That will help your cholesterol overall, unless this is something that's genetic.
Right.
You can do something as little as walking. You don't have to do any kind of Peloton or HIIT workouts or weightlifting. Walking is the easiest way to burn calories, and just being in a calorie deficit if your goal is weight loss. Also, if you don't have to lose any weight, then I would just say you need to probably switch out some things in your diet that maybe aren't that good for you and find alternatives. Oil, meat, snacks, things like that.
Yeah, I mean, can you lose weight just with exercise alone? I
No.
know the answer. No. The answer is no.
No.
Because if if you I mean, if you look at me, you can tell I'm not exactly skinny. Okay, but I work out almost every single day. But when I work out for an hour, I'll burn 400 or 500 calories. Okay, now 400 or 500 calories is not very much. Okay, I can eat that very, very quickly. An apple is 100 calories. A banana is 105 calories. So you have to modify your diet as well as increase your exercise.
We depressed a lot of people that are listening. But,
Sorry about
but
that,
what I'll
you know?
say, I agree. I piggyback off of both the things that they said. I think you have to be regular with exercise, right? And that's exactly what Dr. Gold was saying before about, can you just do something once, lose weight for a little bit, and then just kind of stop? And then, no, you have to be regular about it. And with or without weight loss, exercise is beneficial to your health, especially your heart health. So being regular, even 20 to 25 minutes, ideally 30 for multiple days per week is got a tremendous benefit from a cardiovascular standpoint. And I think you have to look at it differently than weight loss. Weight loss and exercise are, they go hand in hand, but exercise has benefits, aerobic exercise specifically, the kind where you're breaking a sweat. If you're on a machine in the gym or at home and you're kind of pedaling really slowly, or you're walking really slowly, you're probably not getting that much benefit. But if you're breaking a sweat, if you're getting your heart rate up, that's the best kind of exercise, aerobic. You don't have to be running. Right? And walking is a great exercise, especially if there's hills. So.
Question is,
So for those who have higher rates of high cholesterol, is it typically detected in men or in women? And then what are the symptoms for each that you notice?
I haven't really noticed any symptoms that I would say like patients come in when their cholesterol is high. But obviously, if something like chest pain, we're going to check your cholesterol levels. If you come in with diabetes, we're going to check your levels. There's rare genetic conditions which can cause some kind of things we'd find on your physical exam. Very, very rare. I only really read about them in textbooks, but I don't know if, I guess, let's say your triglycerides were through the roof. I mean, he said 1,000 earlier, but it doesn't have to make it that high. If you came in with abdominal pain, ended up having pancreatitis, that is a symptom, but it can be caused by a lot of other things.
Is there a difference between men and women?
I don't think so. Not really.
It's one of the few things where there
Yeah.
isn't a difference between men and women.
I think people assume that it's more in men, but
Right.
it's not. Women are equally affected.
Right.
Yeah.
And also women, to some extent, are protected prior to menopause, but they catch up very quickly. So it's really not a protection.
I think the sad truth here is that you're right. There really are not symptoms of high cholesterol unless it gets to a point where it's very high and it's causing damage. So that's why it's a silent killer. I mean, not to be a buzzkill here, but it's a silent killer. And that's why screening is important. That's why you have to get blood tests and you have to, see your doctor every so often and get that, even in younger people, because it could be identified early.
All right, good. Well, thank you, everybody, for joining us. I hope you learned something. I hope we were a little bit entertaining and not too boring. And if you have questions, you can always make an appointment to see Dr. Dixit, myself, Dr. Sayanlar, and we'll be happy to see you.